Well, thank you so much, Farisad, for inviting me. So I really tried to see what to do. I know what I'm expert is already Dr. Sapkota did, the stroke, which is the commonest things, but we see so many varieties of cases in the intensive care unit. And the easiest way I found to cover it is to put it into cases, because it's really each topic might take many hours just to cover. So trying to touch in a case presentation with some multiple choice questions on it. And then I want it more interactive, really. Just kind of feel free to interrupt me at any time so that things not clear or so. But it is going to be touching, like I said, in a different kind of scenarios that we usually face in the intensive care unit and see among them. So this various cases, so basically this is about the prognostications of cases after the cardiac arrest. And this is a big topic, that some patient was found down, was resuscitated, and then we come and ask as a neurologist, okay, what is the prognosis? Is this patient going to be recovering? Is this patient going to be a vegetative state? Or they're going to have a good outcome? So it is a very challenging topic, and I got to convince it's one of those consults I don't like, honestly, but we have to do, because a lot of time it's very emotional too to the family, and it's just kind of trying to predict things, and sometimes the accuracy, nothing there is 100% accuracy on those one. But basically, this is an evolving topics. The fairest, and it's all, honestly, it is only based on the clinical criteria, how you prognosticate someone. It is not about test. The test, it does help, but it is all about the neurological exam of that patient. So we used to have something called Levy criteria. That was done mostly in Europe in about 210 cases in the intensive care unit. This is in 1985. So until 2006, the AAN is the American Academy of Neurology. So basically what they did, they looked at studies from 66 to 2006, basically. And they trying to see basically what are the sharing that will give a poor outcome in those patients. So the question here, in the 2006 American Academy of Neurology practice parameter on predicting outcome in comatose survivor after cardiopulmonary resuscitation was based on an evidence-based review of a literature and analyzed the specificity of individual to predict poor outcome before the era of therapeutic hypothermia. So this is what I'm coming to. This is becoming very challenging now since we start as you know, the American Heart Association, in their guideline in 2010, they said hypothermia is very helpful. And so it became a standard of treatment in selected patient of cardiopulmonary arrest is to put them in their hypothermia. So it does very well, but at the same time, it does confound it what we do. So which one of the following? So if I want to ask this question, someone had a cardiopulmonary arrest, just as a simple, when you see those patients in the unit, what test that, and I'm sure you guys, you do it, that you feel from a patient you have, they tend out that they have a poor outcome later? What finding? And then we can exclude one of those. So 4 of those are poor, and one of them is not. So the cornerstone of prognostication is the brainstem reflexes. This is the most important one. Brainstem reflexes, you guys, you do pupillary, corneal, and the gag reflexes. But the two that it was based on, the two that and they have very high specificity, is the corneal and the pupillary reflex. If someone had an absent corneal and a pupillary reflex by 72 hours from having found down and was resuscitated, this is a very poor prognostic finding. This is, I stress again, before the era of the hypothermia. So you guys, those cases you see now, right? I know most of the hypothermia, they go to the CCU, but I'm sure a lot of you might have, in the other unit, have patient with hypothermia. And then I'm sure everyone handled a case that was found down and was resuscitated. So, absent of brainstem reflexes, we already answered it. We said brainstem reflexes are what? Pupillary reflex, corneal reflex, gag reflex, and the vestibulo-ocular, which is sometimes we do the doll's eye or so. But like as I said, the two clinically that is we have high specificity is the pupillary and the corneal reflex. And so the corneal reflex, is anyone can show me how they do corneal reflex? What do you do exactly? So you touch the eyeball, or it's basically more you want the cornea, so the black one. You come in and just touch it. But although honestly, sometimes I touch just the eyelashes. It's a corneal reflex. It's one of the old neurologists I trained with. He said just puff air inside the eye. That's a corneal reflex. If someone try to put air over your head, you blink, right? So the corneal reflex basically. Any reflex, when we're talking about reflex, we have what we call it afferent and efferent. The afferent is the sensory, right? The efferent is the motor. So in the corneal reflex, the afferent is the trigeminal nerve, which is going to go to trigeminal nucleus into the pons. And the efferent through the facial nerve. So it's connected to the facial nerve. The seventh nerve is going to come and blink, basically. That's where we're looking. The pupillary reflex also is an afferent. You flash a light, optic nerve, you see it come back again through the oculomotor nerve, so the second cranial nerve, and coming back through the third cranial nerve. So those are the tests, but at the end, their nuclei are in the brainstem. So that's why it tests the integrity of the brainstem. So this is a very important in someone. We want to see how the good outcome or the poor outcome. Although I know that pupillary reflex, you use it for so many things. Someone impending to herniate, for example. The second, the burst suppression pattern on EEG. I'm sure, is any one of you from trauma unit? The trauma, they don't, okay. So the trauma, because I know, because we do this with medication, this burst suppression, basically, sometimes we call induced coma, phenobarb-induced coma. And a lot of the traumatic brain injury, to treat the increased intracranial pressure, they do that. So this pattern, basically, the EEG, as you see, is just activities. I'm sure you saw many activity, but in those one, what we see a burst of activity, then a flat line, and then a burst of activity and a flat line. So when we see that in the EEG in someone who had a cardiac arrest, this is a poor sign. This is a poor prognostic sign. And usually we see that in the patient clinical will have what? The myoclonic, you see that they jerking all over. You see they're just continuously jerking. And you see sometimes it triggered the ventilator very high. And a lot of times, can we sedate him? Can we do this? And we said, well, in this case, we treat the nurse and the ventilator, not the patient. Because you're not going to suppress it. It's just kind of you want to calm things down. But this is in the presence, you know. So in other words, we answer E is a bad sign. So now a myoclonic jerk. And there is different myoclonics, by the way. But a myoclonic here, we put in myoclonic status epilepticus. So the patient, they just jerking continuously, multifocal from, their face twitching, their arm jerking, and their legs, and sometimes even their belly. And then in the EEG, you see that pattern. That's what we call it, a myoclonus status epilepticus, and this is a very poor sign. Because there is another type of myoclonus. There is some patients sitting quiet, and you came and you do this startle or you hit, and then they jerk. So that's what we call it, a post-anoxic myoclonus or Lance Adams syndrome. And it's not, because some patients, they might have that and they're talking to you. So that's not a poor sign. The multifocal, myoclonus with the EEG, this pair suppression, this is a very poor sign. And then we have extensor motor response. You see here, 4 of them is true, and the one that is not a poor sign is a good answer here, right? Because everyone else. So extensor motor response. Is that a poor or a good sign in that setting? It is a response. So if they respond, it's not a poor sign. Yes, in general, when they posture or they something, we consider it poor in general, but in this setting, it's not considered a poor sign. Absence of response is a poor sign. So you pinch them, those patients come and you pinch them very hard, and they're not responding. And then a lot of time when you say the pinch, you make sure, try avoid the feet for some reason, because a lot of those patients, they might have neuropathy. Neuropathy is so common. And so if you pinch the feet neuropathy usually starts in the feet. So they already have damaged pain fiber there. So we do the arm, you can do the nail bit. I like to do the, although sometimes it can cause hematoma, but the flexures and the joint, especially like the elbow joint. So it's very painful. And you can definitely, sometimes you can go and some patients also twist their, when they are edematous, it's a little bit difficult. But response to motor. So this is an important in the examination. If you ask me, the 2 important parts in examination to prognosticate is the brainstem reflexes and the response to painful stimuli, or the best motor response. So you pinch them and you see how they respond. Even if you get extensor response, is not a poor sign. I'm not going to say it is a good. There is here what we're talking, there is a clear, very poor sign. They're not considered clear. They're not good, but they're not a poor sign. Okay, so you just look at it into that. So in this question, it raised the hypothermia. And I know this one we talked about it more, but the hypothermia, let me ask you, what does hypothermia cause? And why we cool those people? If someone you cool on
decrease their metabolism.
Yes. So basically, what you're trying is to decrease the metabolism. But if I cool someone, if you're cold, what are you going to do? And what is shivering does? Huh? The shivering does is going to increase metabolism. And so how do you block that? Yes, that's why we give them paralytic and sedative. And so, you see, we're doing so here in hypothermia and that's important, guys, because sometimes you have patients with central fever. It might not be a cardiac arrest, but you don't want to create shivering, basically, because shivering, you create the reverse, because of the whole idea about bad fever or certain things that you want to correct is you don't want to increase metabolism and oxygen needs. So that will lead to more damage, basically. So in a hypothermia, the protocol, and who is the patients that will benefit from hypothermia the most? What kind of a cardiac arrest? Huh? A witness, but what type? You have many types of cardiac arrest. They could be asystole. They could be ventricular fibrillations, right? Or PEA. So basically, the ventricular fibrillation are the one, those they benefit the most from the if they are cardiac arrest due to ventricular fibrillation, the people that they're shocked, basically. In other words, if they shock the person, then those are the ones that they benefit from the hypothermia. And when we do the hypothermia, because the protocol, you continue, this is for 24 hours. I know a lot of times we do a partial hypothermia here in this hospital. Many times they rewarm the patients before the 24 hours. But basically, you put those patients on the paralytic, on the sedative, that's the ideal protocol. You cool them down below 33, right? And then you start rewarming after 24 hours, but still you want to prevent shivering. So those medications, theoretically, until you warm enough, then you wean off the medications. And so when we say it's suppressed, the hypothermia is not going to just suppress metabolism in the brain. It's going to be in any other organ. And the organ that clear medication are the liver and the kidney, right? So those medications, instead of staying for 24 hours, they're going to stay for 72 hours. So if I got a consult and come and prognosticate this patient, or this patient is unresponsive still, we usually want to wait the recommendation at least 72 hours after rewarming. So it might be day 6 from the event happening. In the previous one, you can do it right away after 24 hours. But this one, because, and this is still we're learning how it affects, but we want to make the medications, whatever this patient medication receive, they're going to stay way longer because of the effect of the suppressed, even those enzymes clearing the medication in the liver were suppressed at that time, or they don't regain their function till 72 hours later. Okay. This neuron-specific enolase, this is also something we do it on the spinal fluid, and in some studies was found to be beneficial. Now with the hypothermia, it messed up, so we don't use it. Honestly, like as I said, is less costly, and we rely more into clinical examinations. And the way we look at, there is some cases, very slam dunk, very poor. You find the sign. But the majority of the cases into this gray, and that's what makes it challenging. And so how you approach them, this is very difficult, but sometimes you have to look at the other comorbidities and definitely patient age, they have any living will or not, because at the end, the long term is going to lead a long-term care. It means peg and trach and those things in some patient if it is not clear. So this is just kind of what we talked about, just kind of about the hypothermia. Anyone had any question about those? They're going to come some other problem again, but anyone? Justin Bieber, man, no question. Okay, so this is the second one. If basically in a patient with increased intracranial pressure, and this is, we deal with those a lot. I know in neuro you have them, in trauma they have them a lot. The presence of which one of the following chronic condition would be the most compelling reason to use mannitol other than hypertonic saline? And this is now, I know you're dealing with this. Every one of you dealt with mannitol, right? And every one of you, I'm sure most of you dealt with 3% sodium. So basically here, it's basically asking for the side effects. If the patient had, which sometimes there is each one had, and it's going to come some problem. Each one has some benefit over the other. The efficacy, most of the study, they consider them the same, but in certain condition, the hypertonic is better. And we come to that. So I have hypoalbuminemia, hypocalcemia, hyponatremia, hypotension, or hypothermia. So you have a patient, and the physician gave you an order, give a 3% sodium. And then you looked into the lab, and you have to tell them, or you want to look into this lab and tell them, hey, do you know this thinks at this? Which one is going to be? In other words, if you have a hyponatremia, if you have a sodium of 118 and you give it 3% and you make it 140, what does that can do? Huh? Edema where? No, this is not the rebound yet, so it's not into the cerebral edema real. So there is a conditions, and a very serious condition sometimes. It's called osmotic myelinosis. So if you have an osmotic, the osmolarity depend on what? Depend on the sodium, the urea, and the glucose. But the most effective osmolarity is the sodium. If you put the serum osmolarity, what factor affected? The sodium had the most. Because they said normal sodium, what is it, around 140, 135, 145. So you have 2 times the sodium. So this is by itself is going to take you to 270, 280. And then you have the glucose, you divide it by 18, and you have the urea. But especially, so if I have someone, the same idea, someone blood sugar 1,000, and you drop it, boom, to 100, this sudden shift in osmolarity, or the sodium, too low and you suddenly make it high, those sudden shift in osmolarity is called what we call it osmotic myelinosis. The term myelinosis, it means what? The myelin into the brain. So it affects mainly the myelin in the pons. And it can make patient locked in, by the way. So, right, we conduct through the tracts is with this myelin in our central nervous system. And the common disease take the myelin is what? Multiple sclerosis, say, for example, that's the known disease. But one of the acute things, if you have a sudden change in osmolarity. So theoretically, if you have someone with significantly low sodium and you give them 3% sodium and it take it too high rapidly, then that can cause this condition. That's why when we make a shift in the sodium, you don't want it by more than a 10. In someone hypo, okay? You don't want to, the same thing, someone hyper, and you drop it way down fast, it can cause the same. So this is all about the sudden change in osmolarity. That's what causes this. So in general, if you have a 3%, make sure the patient does not have a significant hyponatremia, especially a sodium below 125 or so. And so you can basically relay that, hey, the other has nothing to do with it, okay? And we have more questions coming in this between mannitol and the 3%. But it's just kind of to say, the 3% in general, they are good in someone who had herniations. They act fast. So so you follow the pupils, right? When we say neuro exam, and a lot of time you guys, we get a lot of call, hey, his pupil now are unequal. And sometimes it's significant, sometimes it is not, right? So a lot of time I've seen it, someone had a protropium, just kind of those inhalers, because some of them is present, and if they ooze out, they can dilate the pupils. But in a setting, if you know the patient you're taking care of is a patient that might herniate, is having a cerebral edema, the pupil is very important to keep track on. And so when the pupil starts to dilate, what does that mean? What is happening in the brain to let the pupil to dilate, basically? Huh? It's swelling, yes, it's swelling, it's happening, but what is the swelling leading to? Intracranial, but why intracranial pressure affecting the... so if the pupil dilate, which cranial nerve is affected, in other words? I'm sorry, I should have really put some pictures for you guys. I know with the problem we make it a little bit dry, but it's the third, right? As we said, the afferent. So if you compress the oculomotor nerve, and that's when when we have a swelling in the brain is going to herniate. There is no space to go out, right? So there is this condition called transtentorial herniations. You know, we have the meninges covering. We have a fox in the middle. But between our brainstem and the upper part of the brain, there is this, we call it tentorium. And it has the sharp edge. So when it herniates, it can compress into that third nerve coming. So this is, we call it the transtentorial herniations. And in those cases, we know 3% sodium, they work faster than mannitol. So if I have a patient impending or he already herniated, then in this case, the 3% do work better. But as I mentioned, theoretically, just make sure that the sodium is not too low, that you want to raise it too high. Okay, so we have, this is a common thing too, we have fever in a patient with acute ischemic stroke has been associated with poor outcome. Fever suppression is recommended, but there is no consensus about whether induced hypothermia is beneficial in this setting. Which one of the following events is associated with fever suppression may have deleterious effect on the patient with acute stroke? And I think we answered it. Cardiac failure, cutaneous vasoconstriction, dyspnea, hypotension, or shivering. Right. So when you put a cooling blanket and the patient shivers, that can make things worse. As we said, shivering, it does trigger a lot of metabolic activity. So it's going to increase the oxygen needs, and that's what you don't need. And that's why sometimes we sedate those patients. So if you have to cool them, you're going to make sure they are sedated. And if they start shivering, they might need to be paralyzed. Well, if the fever, there is no other options. In general, we do recommend definitely, it's just kind of, sometimes I put the medication just around the clock. A Tylenol, certain amount, you just put it every 4 hours. You know, now we're going to have, unfortunately, more and more restriction on the dose of the Tylenol. It has already dropped from 6 to 4 grams total, and now I think they're in the verge of dropping it more. So we have to come up with better plan how to treat those patients. But in general, just you got to make sure if you put someone in a cooling blanket, and someone had a CNS, so we just put a stroke here, but they have a CNS injury, you don't want shivering, basically. Okay, this is just kind of simple question, but physiology, if someone take an exam. So we have a healthy young women, and put 2 lines and they're healthy. Took a recreational drug that had inotropic properties, but no effect on blood vessels. As a result, her blood pressure rose from her baseline 100/60 to a 140/90 for 3 hours, and then gradually returned to her baseline. If her baseline cerebral blood flow is 50 ml per 100 gram per minute, that's how we measure the blood flow. The cerebral blood flow, and this is very important concepts when we treat to have that. So, because in general, I say if the cerebral blood flow, the normal 50 per 100 gram per minute, if it dropped below 12, we know the patient completely stroke. If it dropped below 20, they don't function that area. And so that's part of the concepts on how to treat the stroke. How to maintain, and that's why in a stroke we say we need a high blood pressure and all those things, because you don't want that blood flow to drop. So here he said basically what was her likely cerebral blood flow during those 3 hours. So it dropped, it has this change, and basically what is that affecting? Is it going to be 25? Is it going to be 50? Is it going to be 75, 100, or 150? Anyone? Any clue? I heard 50, and 50 is the right answer. Basically, the brain had what we call it cerebral autoregulations, and it can accommodate a significant variation in the blood pressure without changing the blood flow. When it goes beyond that autoregularity, then that's when it can cause trouble. If it drops too low, it can cause ischemia. If it is too high, you have hypertensive encephalopathy, right? You've seen patients completely altered. I think we just have one 3 days ago in the MICU, and came very agitated, completely altered. They have to really restrain and sedate him and intubated him at the end to get a CT done because of and his blood pressure at that time is 240 over 130 something. When the next day, when it was normalized, he was back to normal. So that's a hypertensive encephalopathy. So the brain, the blood flow went beyond that autoregularity. It's going to cause any sort of things. It can come as agitation, can come the patient less responsive, so it's encephalopathy at the end. But it's just kind of here to teach you a lesson that the brain has a wide, more than the other organ, area can accommodate significant change in the blood pressure without some change, without changing the blood flow. Okay, so we have someone comatose or altered, drowsy, barely arousable. And a lot of times we get the consult, we say multifactorial, this and that. There is so many different causes. And so definitely one of the causes is metabolic. And I'm sure you've seen a lot of, especially in patients with kidney failure or someone with hepatic cirrhosis. Those are the two common. You will see a lot of what we call a metabolic encephalopathy. So in neurological examination, which one will tell you this is metabolic, this is more pathologic, this patient had a brain injury? You got to look for something causing this instead of a metabolic encephalopathy. Was it asterexis? Do you guys know asterexis? And asterexis basically when you hold the patient's hand like that. You've seen this, right? So sometimes you just hold it in their hand, and that's what they do. Basically, they lose the tone of the muscle, so it drops like that. This, we call it an asterexis or a flapping tremor. That's another thing. It's one of the features, if it is generalized, of metabolic or end organ. Someone with hepatic failure or renal failure, you can see it commonly on them. So this can be seen more with metabolic actually, unless it is unilateral, but it's usually generalized. Fluctuating course. You have cases that, he was just talking to the family very fine, and the next hour he's completely altered. And then 2 hours later he's fine and then altered. Or they have this sundown in the floor you see. So this could be with any cause of encephalopathy. And this is very common, right? So this is one of the features of encephalopathy, that they fluctuate. That's why you guys call in and they keep giving Halidol and don't give Halidol, and they keep giving Gedone, and you're giving someone Parkinson. So that's why, or sometimes Ativan, and you make them agitated more. I know they're very difficult patients to take care of when they have this fluctuating or delirium. But this is a feature of any cause of encephalopathy. It could. And especially we see it more if either the patient had a severe metabolic encephalopathy or if they have it mild but they have underlying dementia. And so it could be so. Loss of pupillary function. You flash the light, the pupil either fixed dilated or they just don't react to light. If they have loss of pupillary function, the pupil is very resistant to metabolic and medication change. And so if you have it and you make sure that, especially if they're unequal, then that's more going to be concerned and there is something pathologic. So that's my indication to image the patient. There's no indication for me someone had a urea of 10 and he's fighting to go and do a CT scan on. You see, there is explanation for that, unless you're worried about it. Unless if they have anything other pathological going to appear on the exam. If they have a bleed, they're going to be weak on one side or the other. But just to change your mental status, fluctuating, that just could be from the metabolic abnormalities. But the pupil, we said, is very resistant. Sometimes, I don't know if I come across, I do tell some tricks to the nurse in the ICU if the patients, their pupil is too small. And so you see some patients, they just don't respond. It's kind of too small. What to do with those? And a lot of times there is a reflex. We call it the ciliospinal reflex. I pinch them in the neck, here in this area, in the lower neck. There is the pupil dilates through sympathetic innervations, and it's coming from the neck, basically. So you pinch, you stimulate it, and you can do it in any one of your patients, and you can see the pupil dilate. So you can flash the light, and you can get the constriction. Because sometimes I know they're too small to get it. So do that, and you can get a better response. But especially if it is an unequal pupil in a setting of fluctuating mental status, that might trigger an imaging. Multifocal myoclonus is the same idea like the asterexis. So it also could be seen with that. And myoclonus, basically, when we use the term myoclonus, so myo is a muscle, right? A clonus is a jerk. So basically, there is positive. Do this to the muscle jerk, right? So this is what you see in myoclonus. In asterexis, you lose the tone. So it's a negative. We call it a negative myoclonus. But if you see someone like that, hypoxic injury, but sometimes you can see those in someone with severe metabolic abnormalities too. So multifocal could be tremor, very shaky, especially in patient with alcoholic liver cirrhosis. You can see it very bad, and they're so shaky and tremulous. So that also could be metabolic more than being pathologic. Any question, guys, so far? Or do I talk to myself, or was it good? Okay. Okay. So for a patient who has sustained a severe traumatic brain injury, induced hypothermia is most likely to be beneficial in which one of the following setting? As just before I go through the options, in general, we do not use hypothermia yet for traumatic brain injury. It was not done. The study was done basically in a patient after cardiac arrest. But after traumatic, it is not. Although there is one of those situations, very annoying, that after a traumatic brain injury it might have a place and some centers they used it for. So before intubation, in a patient with refractory intracranial hypertension, in a patient with systemic hypotension, in the first 24 hours after the injury, while hyperventilating the patient, while initiating prophylactic burst suppressions. You remember earlier we said sometimes we do prophylactic burst suppression. So there is no one of you in the unit, but anyone who work in trauma, they do a lot of ICP monitor. Because after traumatic, what you're afraid of is increased pressure. With the trauma, the brain is swelling, and there is increased pressure. And so this is the cornerstone of how they manage it. They want to get that pressure down. The ICP usually is 5 to 15. If it went beyond 20, it can cause a lot of problem. And the longer it is, the biggest the problem, the damage to the brain that could happen. And partly part of it can induce ischemia. Because we have the cerebral blood flow, that equation when we say 50, that's equal what? Equal the mean arterial pressure minus the intracranial pressure. So if you have a high intracranial pressure, it means you have a low cerebral blood flow, right? So in that way, you don't want the the ICP to stay high. So basically, if I have refractory, that's the answer. If you have a refractory intracranial hypertension, how we manage those? How you manage it, definitely there is different things. You want to, the patient is supported, is ventilated. In the first 24 hours, in general, sometimes we hyperventilate. We hyperventilate, but we said keep the PCO2 between 32 and 37. The PCO2 normally is around 45, right? So when we hyperventilate, because basically hyperventilation, when you wash out carbon dioxide, you do what? You vasoconstrict. So in the first 24 hours, this vasoconstriction is harmful. So it's not recommended in a traumatic brain injury to hyperventilate in the first 24 hours. Other things, we use the diuretics, right? Those like mannitol to decrease the pressure, like the hypertonic saline. We use that. Sometimes might have some success, sometimes they are not. And then you use a drain. Someone put an EVD that you have anyone dealt with external ventricular drainage, especially if you're working in the ICU, in the Neuro ICU. We have patients with bleed, they put a drain, so draining the CSF out. But partly, even one of the importance of that, you can measure the ICP. And then we have the extreme. We have a patient 2 days ago, and it was done on Sunday morning, actually, or Monday morning, not Sunday morning. They came to us from another hospital with a big cerebellar stroke, went into obstructive hydrocephalus, and their pressure went way too high. He went into coma within 2 hours from arriving. So what they did, they opened the skull out, basically. You get the skull out. We call it decompressive craniectomy. So you want them, as told many patients, you injure your hand, you have the air, you swell the amount you want to swell. There is no, but in the brain, you have a tight space. You can't swell more. So sometimes you have to do this decompressive in some patient to get it out, the different things. So the whole thing's about this ICP not to stay high that long. And as I said, if it stayed persistently above 20, that's very harmful to the brain. Okay? Okay, this is another question between the mannitol and the hypertonic saline, because those are medication you're going to deal with. So which one of the following characteristics distinguish hypertonic saline from mannitol when used as an osmotic agent? So what is the idea when we use this? What do we do? What are we trying to do if I use mannitol or a hypertonic saline? Excellent. Exactly. That's what it is, basically. So what you try, and you have a fluid outside of the vessels, and you want to get it into the vessel, get it off the parenchyma from the brain tissue into the blood vessels again. And how you do that, there is a simple rule, I think, from middle school. We know that osmosis go from where? The water move from low to high, right? The area, if there is too much salt and you have less salt, it's going to move from low to high to equalize, basically. So when you give this 3% saline, or you give the mannitol, basically increase osmolarity inside the vessels. And so the fluid through that blood-brain barrier is going to move into the vessels. So that basically, and the type of the edema we treat is called what? There's 2 types of edema we treat. Should have, mentioned this earlier. We have what we call it cytotoxic edema, and we have what we call it vasogenic edema. Right? So the cytotoxic, that's what we're talking about. That's which can result from anoxic brain injury, from a stroke, from traumatic brain injury. Those are the cause of this. But the vasogenic are the one with the brain tumor, are the one with inflammations, like multiple sclerosis inflammations, if it is so bad, or someone had a bad encephalitis or an abscess. Those, we call it vasogenic. And that's usually the treatment is different. Those we treat with steroid. Vasogenic, right? So someone with a tumor and brain edema, a lot of time, solumidrolagram or this, so you have a high dose. But the other group is cytotoxic edema. That's you treat with osmotic, basically, agent. Either the hypertonic saline or the mannitol. So hypertonic saline is a less potent diuretic. Those are the options. Just look at them and see which one could be correct. Hypertonic saline is less likely to cause metabolic acidosis. Hypertonic saline is less likely to cross an intact blood-brain barrier. Hypertonic saline is more effective as an osmotic agent. And hypertonic saline is more likely to cause a rebound rise in intracranial pressure. Those choices are important in Because when you deal with those medications, sometimes a lot of time it's better to know some of the side effects, so at least if something happened wrong with the patients, you can guide the physician, many likely. Is it a diuretic? Is hypertonic saline a diuretic? It is. Mannitol is a diuretic. So number one is the answer. But hypertonic is less likely to cause metabolic acidosis. Both of them, they do metabolic acidosis. Is less likely to cross an intact blood-brain barrier. Both of them are less likely to cross the intact blood-brain barrier. You see, in the stroke and those one in the acute phase, the blood-brain barrier might stay intact. In the subacute, they might be breached. In the tumor, from the beginning, the blood-brain barrier is not intact. That's why they enhance. When we say do MRI with and without contrast, that contrast, if it showed into the mass, then it means the blood-brain barrier is not intact. And one of the things make the blood-brain barrier not intact is a tumor, for example, or especially malignant tumor. You know the blood-brain barrier is the endothelium, basically. There is different things, but the most important is endothelium in the capillaries. So the brain is protected, is one of the organs you have to protect, so it's not going to be exposed to any change in the environment and those, because there is so many harmful things. If everything can get access to the brain, it can mess easily. That's why it has a barrier, basically. Even a lot of the medication, they do not cross the blood-brain barrier. Most of the antibiotics, they do not, unless in a case of meningitis. When you have inflammation, you break the blood-brain barrier. That's when they reach. Cancer medications, a lot of them, they don't. That's why they injected them intrathecally, some of the chemos, right? Because you have this barrier just to prevent that. And then one of the important things to know about is to cause a rebound rise in intracranial pressure. So suddenly you stopped it. In some patients, they can, that is molarity. We said we shift the fluid from the parenchyma to the blood vessel. You stop the medications, say, suddenly you can get the reverse. And that we call it rebound. So you might get worsening in some patients. And so definitely we have to stop it at one point. But in some cases, if you sudden a new worsening, it can raise that possibility if they are in mannitol. And both of them, they cause it. Both of them, they cause it. Mannitol, definitely, whenever it is problem, it can cause renal damage. So if someone with kidney failure, we don't use mannitol or creatinine too high or so. Okay, so patients with acute ischemic stroke, I don't know it was mentioned last time or not. The current recommendation is to maintain serum glucose at or below which level? 110, 140, 170, 200, 240. It should be known, right? Because you're taking care of those patients. So what is your target? Blood sugar. There is a study, I remember when I was doing my residency, our center used to be a part of it. It's called GRASP. And actually, some of those patients, we put them in insulin drip. So the whole study was funded by the insulin company, basically, and to titrate it below 110, but definitely need a lot of monitoring. So it's practical is not practical. They have to be in the unit, very closely monitor to keep it below 110. So from practical point, because you're checking the blood sugar every, 4 times a day in those patients, or every 4 hours at the most, right? How frequent you can check it, the blood sugar in the unit? Every hour in some patients. Well, every hour is good. You can be more tight if it is every hour. In general, just for practicality, we say less than 200. Because you don't want hypoglycemia. You don't want it below 80. It's harmful in a stroke. And too high and hyperglycemia is very harmful. It can cause malignant edema from the infections because it can trigger a lot of inflammatory reactions in the stroke area. So don't want it high, as we know is harmful, and you don't want it, you avoid it too low. So if we put the target low, you're not going to guarantee it between the time you didn't check it that it has dropped below that target. basically. So that's why they put the 200. Okay, so we have a patient, 68, developed pneumonia 2 days after surgery for an abdominal aortic aneurysm. And over the next 3 days, she developed sepsis, bilateral lower extremity, DVT, progressive decline in hepatic and renal function. 6 days after her initial surgery, she started having generalized seizure. Which one of the following types of medication would be the most likely cause of her seizure? You get the question. So someone, this is for us, we involve after the patient have seizure. But this is a patient had a fever, had a DVT, and pneumonia basically, and was treated with multiple medications. And then after that, she had a seizure. So the question came, was the medication cause a seizure or not? And if it is medication, which group of medication that we use very commonly and it could be causing seizure, but we do overlook? ACE inhibitor, anticoagulant, because he put that one, benzodiazepine, beta blockers, or beta-lactam antibiotics. So angiotensin like lisinopril and those medication, right? I've never known that to cause a seizure, so that's not the case. Anticoagulant, either warfarin or Lovenox or sub-Q heparin in a therapeutic dose. So I don't think that's the cause of a seizure. It's a common medication. Benzodiazepine it treats seizure. It does not cause seizure, right? Unless someone was drawing from it. So benzo is not going to be causing seizure. It can cause agitation in some patients. I mean, you feel like you're going to calm them down, but some patients just can react agitated. And beta blockers like metoprolol or Enderal or those kind of things, and they're not a cause of a seizure. One left, right? So, the beta-lactams, which one is that? What is beta-lactams antibiotic? It's the cephalosporin, common of those. So sometimes they can cause the seizures. They can be a cause of a seizure, and we overlook those. So it's just kind of to be aware. A lot of times when someone had a seizure in a setting of some new change, you have to look for different things, because seizure, yes, it can result from a brain injury, more level, but it can be medication side effects. And we have one of the common, the medication that we have seen seizure from, two common are the Wellbutrin as an antidepressant and Ultram or the Tramadol for pain medications. And many times I have patients with new onset seizure. Wellbutrin, you will know about it, but Tramadol, some people they take it not legal, and so or just off the street. And I remember one time I have a high school teacher really came with a bad seizure, but his father was with him in the room and they wouldn't say anything, and we don't have any cause for the seizure. It's just kind of digging, okay, what could be, and unfortunately it's very challenging when you have someone you don't find a specific cause, but they're not telling you the truth. They're hurting themselves, because you're going to either take a decision to put them on medications, or take a decision to do unnecessary workup like a lumbar puncture, like an MRI with a contrast, which is, in some cases, it can cause some problem, for example, the contrast in those. So lately, he just kind of went by himself. He said he's taking too much Tramadol. So those are very known, but also some of the group of the antibiotic, they can cause it. Levaquin, they do. We know Levaquin is one of those medications too. In this. Okay, among patients treated for status epilepticus whose clinical manifestation appeared to have stopped. You have a patient, came to you in the unit, season, right? We just have one 2 days ago in the unit. I think she was admitted 10 times with a status epilepticus before in the MICU. She just left, I think, to the 9th floor. So appear to have stopped. What proportion continue to have electrographic evidence of a status epilepticus? So when we have a seizure, we tell the people the seizure is you have the clinical seizure, the jerking acts, but that as a reflection of the electrographic seizures. And so the pseudo-seizure, the people, they just shaking, but their brain is normal, either the EEG, there is nothing. So that's a psychogenic, or we use the term pseudo-seizure, a different thing. But the question with the status, which is a lot of time, they can't fake it. I mean, and there is some patient they can definitely, but it will be very clear because you will have problem with breathing, you'll have heart rate going up, instability in the blood pressure during this. And those patients, when you stop it clinically, it does not mean you did stop it electrographically in the brain. And so they did a study, they put them in EEG, and after it stopped, they found some patient for another 8-12 minutes, they continue seizing. And what percentage is about 20%. 20% of patients with the status epilepticus, they can continue seizing, which is very harmful because the excessive activity in the brain, which is going to lead to the damage. That's why you don't treat seizure with paralytic. I mean, we have this mistake done before, someone jerking all over, and then some people, they paralyze them. Well, you didn't stop the seizure, you just stopped the muscle, right? And so the damage in the brain is going to be continuing. This is about 20% of the patient. That's why, honestly, and I think we're going to move in this hospital into this direction. Now, the continuous EEG monitoring in a patient with encephalopathy in the unit is becoming part of the practice because there is a large percentage of them, significant, I don't want to say a lot, but significant percentage of them, they are in status subclinical seizure. Someone alter, you don't know what the cause, and they don't have any evidence of a clinical seizure, but you do the EEG and they're seizing. So you got to manage them and suppress that. And, okay. Now this is the last one. Okay, which of the following best characterized current recommendation regarding prophylactic? And this is important. I put it there: anticonvulsant medication in a patient with intracerebral hemorrhage, someone with a bleed in his brain. I'm sure you see it commonly. They are in seizure medications. So what is the recommendation? Not recommended, recommended in all patients, recommended in patient older than 70, recommended in patient with Glasgow Coma scale less than 8, and recommended in patient with systemic blood pressure greater than 160. This is the last question. Pick up. I'm gonna go around. D, Glasgow less than 8. D. B. Recommended on all patients. B. Okay. We have 4B, 1D. Huh? B. Lynn.
Oh, I'm going to go with B.
Okay. B. Huh? D. Okay.
You looking at me, or are you looking at me?
Yeah, it's coming. We can start. It's just
I'm going to go ahead and say all patients.
all patient B, huh? Baker. He disappointed me, guy. Although I honestly mentioned it, the reason I said disappointed because I felt like I discussed it with some of the nurses before. It is not recommended, and it's one of the practice that we do wrong, honestly, and we keep fighting for it. It is the seizure. There is no recommendation to put patient on prophylactic after a bleed unless they have a seizure. You have to have, yes, so the bleed, you have two types of a bleed, right? You have a bleed, we call it cortical. You got to imagine in the brain I have what? I generate the signal from the neurons, which is the cortex, what the gray matter in the brain, the outer layer of the brain. And most of the bleed are deep into the basal ganglia, the thalamus. This is not an area to even cause seizure. So if it is cortical, definitely the risk of seizure is higher than if it is subcortical. Okay? So the general recommendation, it is not recommended to treat unless they have a seizure. But in a cortical, you have to have high suspicion to look for it, which is, that means you might, if the alteration is not explained, you might need to do an EEG. But someone just came with a bleed, and I've seen some bleed like 1 cc, and they are in Keppra. That's not a cause of, okay? So general recommendation not to treat. With that, I'll leave it for question. I hope it was cover some issue, and I hope it was not. I just kind of more really because you're dealing with those things, and I know it is difficult. Neurocritical care, one of the difficult topics in the critical care. I could see that, and but you need just, I don't want to like, yeah, you know in depth, but at least you need to be very familiar with what you're dealing with on a daily basis and when you face them with challenges. Why we doing this, why we do not do this, basically. But it's a big topic. In the future, we can definitely have no problem, but I would promise with Lynn we can select, and you can guys from those topics we discuss, if you feel one that is more you want to know more about, I have no problem to come and give it more details in that topic. But this one, we, as we said, we cover after cardiac arrest, we cover the status epilepticus, we cover using of mannitol or hypertonic in certain way, and then the ischemic stroke, the effect of the fever and the hyperglycemia. All right, thank you. Appreciate it.
Appreciate you.
Thank you.